Everybody, welcome. Welcome, everybody. Glad you could join our Echo Geriatrics clinics today. We're just going to give a couple minutes for everybody to settle in. Okay, great. Okay, so let's see. We haven't had this in a while, and yeah, looks like our good friends are back here. We have Dan Fishberg's new. He's joining us today. Gary, good to see you. Gina Maihara, welcome. Jacqueline is always joining us. Thank you. Janet Clanton, Joseph, Dr. Cohn, and Lay and Michael Tom. Good to see you, Mike. And Patricia Bemis. Good to see you again. All right, so let's do the next slide, please. Okay, just as a reminder, we have free CME here, distance technology, online learning, opportunity to build community and discuss cases. Of course, we can do that in a HIPAA compliant way. We have interdisciplinary expertise at the hub, and this is a community of learning. We're going to all ask questions and share our experiences. Next slide. So yeah, share your cases, any geriatric topic, any challenging cases. Doesn't have to be related to this topic. It's nice if it does, but it doesn't have to. And we want to just share our collective wisdom. Next slide. Just a reminder, confidentiality, HIPAA compliance, those are really important, as well as a safe learning environment. We want to foster a culture of encouragement and mutual learning, not negativity. And a reminder that Echo case consultations do not create or establish provider-patient relationships. What we discuss, cases that are discussed, are really just for teaching purposes. Next slide. And a reminder that in order to receive CME credits, you've registered, but there will be an evaluation link that will pop up towards the end of the session, and all you do is click on that and fill it out, and you will get your CME credits. We provide CME as well as CE credits for social work as well. Next slide. Okay, Zoom logistics, you know about the chat tool, and we're just asking you to put your name and others joining in the session today if you are in the room, if they're in the room with you, and then hit enter. That's sort of our way of taking attendance. And then, of course, use the mute button and unmute if you want to speak. Great. Next slide. And just our little hub team here. There's me, of course. We have Sarah here with us today, Sarah Tompkison. She usually joins us, licensed social work, in case we have social work questions. Lucas Morgan should be joining us as well. He is our clinical psychologist. We have Chad Kawakami as well, joining us back from a long deployment. So welcome back, Chad. He's with the UH School of Pharmacy in Hilo. Okay, so let's see. All right, and we're going to have a special speaker today. This is Lisa Taniguchi. You can wave hello. Hi. She is a clinical audiologist at the University Health Partners of Hawaii Speech and Hearing Clinic. She returned to Hawaii in March of 2017, focusing on expanding audiological services and providing clinical education for speech language pathology students. She's worked at an ENT outpatient clinic, private practice, focused on adult and geriatric care. Her areas of specialty include audiology and vestibular diagnosis, amplification, and oral rehabilitation. So aside from teaching, she has a passion for community outreach, providing hearing screening and spreading awareness of hearing healthcare. So we're really fortunate to have her, and she can shed some light on the questions that a lot of our patients have about hearing aids. So thank you so much, Lisa. Go ahead.
Thank you, Dr. Wen, for having me. I was in on the presentation with Echo in August, I believe, with Dr. Hall and Dr. Samantha Robler. And after that presentation, there was interest in hearing more about where hearing aids have gone and what's available out there. So my goal for today is really just to share some of that knowledge with you. There's new in the works with FDA and over-the-counter hearing aids. I will touch on those things, but there's really kind of cool stuff that's available to hearing aid users, from the big O hearing aids that used to whistle on the back pew aisle. Hearing aid technology has gone a long way, and we are in the world of advancing technology, and things are getting better, faster, and smaller. So with that, I just kind of want to share the overall outline. We'll talk about, what we look for, or signs that someone might be a good candidate for hearing aids. Thinking beyond the basic hearing test, what other information do we need to really help this individual to be, and really focus on patient-centered care? Fitting considerations, we'll touch again on hearing aid styles. That hasn't changed too much in the last 5 years, but you'll be surprised with the range of styles that are available. Hearing aid technology, what was and what we have available now. I also want to touch upon understanding the fitting and the follow-up process with hearing aids. It's kind of, I always use this analogy, it's not like glasses, just don't put it on and say, see you in a year. We really have to make sure that we are fitting them properly, because if a person is not properly fit, there are adverse reactions like headaches or overly sensitive to sounds or worsening of tinnitus. And thinking beyond hearing aids. Hearing aids is not the answer to everyone's hearing loss concerns. We have to think outside of the box sometimes. All right. Now, hearing aid candidacy, I wish it was as easy as this flow chart, but is there hearing loss? No. No further action? Yes. Does their hearing loss impact their daily communication? And from this presentation, you're going to see that there's a lot of mini steps that happens over here and along this way here before we actually fit an individual with hearing aids. I'm going to bring up this audiogram here for patient A and patient B. Same X's and O's. So just quick review how to read this audiogram. Numbers across the top is frequency. Think of a piano, low pitch running to high pitch sounds. Up and down is loudness scale. Soft whispers here going off to 120 decibels is like a jet engine taking off, okay? X's is the left ear, circles are the right ear. Normal for adults is 25 decibels. Okay, so anything above where I'm drawing my mouse here is considered normal. So for these two patients, patient A and patient B, they're pretty normal in the lower frequencies and mid pitches. But when we get to the higher pitches, we see that they have a mild to moderate hearing loss here. X's and O's are the same, but the difference here that I'm going to paint the picture is their daily communication needs are varying. When I explain this hearing loss to a patient, I'd say, you're going to be okay and quiet. It's really those difficult listening situations that you're going to have difficulty hearing the consonants of sound. So you'll hear someone talking, but are they saying fin or tin or steak or snake? They're mishearing the consonant sounds. Again, not in quiet, more so in noisy situations, or listening to someone at a distance, like at a place of worship or in a lecture hall. Patient A says, you know what, Lisa, I really don't put myself in those types of situations. I mainly communicate with someone in a quiet room, and it's mainly me and my physician, or me and somebody coming to visit me at my home. Patient B here says, you know what, I think I should do something about it. I work in a noisy environment. I'm constantly in meetings. I'm giving presentations. I need to hear the questions that are coming from the back of the room. And it's embarrassing for me to ask someone to repeat themselves. So patient A will probably lean towards no, not really impacting their daily communication. I'll tell patient A that's okay, but we do want to monitor your hearing loss. So I am going to still recommend an annual hearing test just to see, honestly, if their hearing is declining or progressing annually. I might push them out to a couple of years, see if we can start to identify some sort of pattern, and keep an eye on their medical symptoms. Patient B, I'm going to push them towards a hearing aid consultation or a rehab assessment to see how much is their hearing loss impacting their daily communication. Okay. So similar audiogram where the higher frequencies or the higher pitches are impacted. We know for the adult or geriatric population that it's the higher frequencies or presbycusis that are affected first. Putting that on the ever famous speech banana, where it maps out where the sounds fall of speech, you see here again that anything above the X's and O's is the areas or the sounds that that individual is going to miss. So for this person, they have no problem hearing the vowels. They have no problem hearing the strong consonants, as I call them, but it is the soft consonants that they're really going to be affected by. Okay. So again, hearing loss is not the only driving factor. There are other social signs or emotional signs that we should all be aware about. Pre-pandemic, before people wearing masks, I would have patients say, you know what, I'm really watching people's faces. Since the pandemic, now that everyone's wearing masks, they're coming in saying, you know what, I'm not getting by anymore. Everyone's wearing face masks. I can't hear them. They're mumbling to me. A common one that we get is they're responding inappropriately during conversations, trouble hearing women's and or children's voices. You know, I don't have a problem hearing my buddies at golf. I have a problem hearing my wife at home or my grandkids when I'm picking them up. And we all know that women's and children's voices fall in that higher pitch or the higher frequency range. They're increasing the volume or the TV radio and say, you know what, it's getting louder, but they still sound like they're mumbling to me. Keep in mind that TV volume across the board is not just adjusting the higher frequencies, it's bringing everything up where it might be over amplifying them in some areas and still not giving them enough in the higher frequencies. Common one, probably the most prominent complaint or hearing concern that I get on a patient's case history is that they're having difficulty hearing in noisy situations, restaurants, places of worship, malls, grocery stores, where there's a lot of other distracting sounds, multiple talkers. They're feeling like, honestly, everyone's mumbling. It's not them, it's everybody else. So these are just some common social signs that say, maybe they might be a good candidate. Maybe they should try something and see if it helps them. Some emotional signs that you might notice that they're avoiding certain social situations. I've had numerous patients say, you know what, I don't go to movie theaters anymore because I'm not getting it. They're blasting away the cars and the guns, but I'm not following dialogue. So I avoid movies, or they avoid certain restaurants. A common one that I always joke about is the Cheesecake Factory because it's marble everything. But they can do little small bistros or boutique because it's more intimate. They don't have a problem there. Feeling stressed or anxious, annoyed, embarrassed in less than ideal listening situations. So individual that's just kind of sitting there, kind of nodding along, maybe bluffing, occasional awkward ha 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 in the wrong places. You might start to notice these things, or caregivers or family members might start to notice these things. Okay. Other things that I look for in their case history, if they have a history of noise exposure. Veterans, I work with a lot of veterans, TRICARE, active duty. We know that there's noise-induced hearing loss, and OSHA wasn't around till later. So those older veterans really are affected by noise-induced hearing loss. If they have a family history of hearing loss or family history of hearing aid use, Dr. Hall at the last presentation talked a lot about comorbid conditions, diabetes, type 2, hypertension. They're more at risk for hearing loss. There are ototoxic medications. The main ones I'm mainly concerned about are they undergoing cancer treatment and cisplatin. Multiple rounds of cisplatin at high dosages can be ototoxic. And if they have a history of maybe ototoxic medication on top of family genetics, on top of noise exposure, they're just at a higher risk of hearing loss and being a candidate for hearing aids. Individuals who have tinnitus. I always let my patients know, hearing aids is not a cure for tinnitus. It's to help you manage and provide you the sound treatments that can help relieve your awareness of your tinnitus. Most patients, once we provide them those higher frequencies that they've been missing, their brain will kind of back off and say, you know what, I don't have to create that sound that I'm missing anymore. I'm getting it. I'm getting that stimulation. So a lot of patients will notice a reduction in their tinnitus, or some will notice that their tinnitus goes away. If their tinnitus is more involved, maybe it's from ototoxic medications or stress, they might need more than just a general amplification. There's hearing aid programs in there that have what we call tinnitus maskers. And again, that's a wrong term to use, not really masking it, but it's providing additional sound, ocean waves, white noise, some fractal tones in the background, that the object is to really distract the brain and say, oh, hey, something else is going on over there. So I'm going to pay attention to that instead of sitting there and listening and focusing on the tinnitus. The more we think about tinnitus, the louder it gets. Okay. Moving on in regards to the needs assessment, I encourage hearing care professionals to really think beyond the hearing test. They're hearing care professionals. We have hearing aid dispensers. We have audiologists. I've seen ENTs who've dispensed hearing aids before, but it really involves in a good assessment and the proper follow-up. So thinking beyond the hearing test, there's extensive speech testing that in a proper protocol that we would do to really say, hey, are they a good candidate for hearing aids? Not just the list of words. Are you hearing in your right ear? Are you hearing in your left ear? We might want to test them with binaural, testing them with a list of words in both ears at the same time. If they have a site of lesion, maybe a dramatic case, an acoustic neuroma on the right side, when we present them binaurally, they might have an adverse reaction or rollover effect where they actually do worse with binaural input rather than monaural input. So they might not be a candidate for 2 hearing aids. They might just be a candidate for 1 hearing aid. Okay. The common complaint when they come in is, I don't have problem hearing in quiet, I have a problem hearing in noise. There are tests available to test a patient in quiet versus noise. We'll throw in some babble talking, some white noise in the background, just to see, hey, if they are in a less than ideal environment, how are they doing? Okay. Do we test them with words versus sentences, with vision or without vision? This is more for the severe cases. I'm thinking like moderate to severe to profound. We want to see their lip reading, of speech reading ability. If they're complaining about mask use, we can honestly give them some objective data of, oh yeah, if you have a face mask on, that's going to be hard for you to hear versus without. We also obtain most comfortable levels, turning my voice up or turning the recording up or down and saying, hey, if you're in a quiet room like this, or if I throw in some background noise, what's a comfortable level for you to hear me? And that will give us an idea of maybe their signal to noise ratio difference. And we'll take all of those numbers and put it in their hearing aids and programming it accordingly. We definitely want to know their loudness discomfort levels and input that data into their hearing aids and calibrate. If we reach those levels of discomfort, then they're going to take those hearing aids out whenever someone slams a door. So we really want to make sure that quiet speech is detectable, normal speech is comfortable and audible, and they're hearing it, and that loud sounds are loud but not uncomfortable. Other things that we want to gather, whether it's before their hearing test or maybe after during the hearing consultation, is some sort of questionnaire. It helps them to put their subjective observations or concerns and make some goals for them. Okay, so a lot of people are familiar, especially in the geriatric department. I've seen residents talk about using the hearing handicap inventory for the elderly. It's 10 questions. It gives us information about their impact of hearing loss on their emotional or social situations. Another one that is commonly used in the realm of audiology is the COSI. I will say, okay, I'm not necessarily giving it to fill out, but I will say, list me your 5 most difficult listening situations at, their first appointment. And maybe patient B, like I used earlier, will say meetings. I'm often conducting them. They're in a room, in a board meeting with glass, et cetera. I kind of get more information about their meeting setup because not all meetings are equal. How many people are in that meeting? He might say, hearing my wife at home, hearing my grandchildren, hearing at church, and hearing improvement when he's on the phone because he's, using the phone a lot. Then I would write all those things down and say, okay, what's the most important to you? And then we'll rank it. And hopefully once I fit them and get through the trial period and the adjustment period, I will bring that COSI back out and say, okay, do you remember the first time I worked with you? You made these, you list that these were your most problematic areas. And it gives us an idea, and what insurance is always asking for is verification of, did you improve their communication and their listening environments for them with your work, okay? Another popular one is the AFAB, abbreviated profile of hearing aid benefit. And again, it asks them in different situations, different speakers, with and without the hearing aids. So we can really compare their benefit from hearing aids. With the use of the case history, with their use of the hearing test, with the use of speech testing, with the use of questionnaires, I'm going to make very specific communication goals with that patient. And really talk a lot about realistic expectations, because it really isn't just put it on and buy and see ya. I'm going to use this one patient I just saw recently. She's a mother of 4. And she said, these hearing aids are great. They're a huge upgrade from my previous hearing aids, but Lisa, I'm still having difficulty in the car. And okay, explain to me what's going on in the car. It's like, while I'm driving in the van, I have my 4 kids behind me. I can't hear a single word what they're saying. She has a moderately severe to profound hearing. And I really had to tell her, you know what, if you were more mild, moderate, I would say, okay, yeah, the hearing aid should be able to help you in that environment. But because of how much hearing loss you have, with the road noise while you driving, your attention should be on the road, of course. And if you have 4 children under the age of, I think her oldest is in high school, you're going to have a hard time hearing them, no matter how many adjustments I do. Even if we try this accessory or that accessory, it's still not going to be a realistic expectation for you. Okay. All right. This is all the buzz lately. I would say every patient that I've been seeing recently, they come in and ask about, ooh, what about over-the-counter hearing aids? So I just want to back up and just briefly discuss where this is at, and where over-the-counter hearing aids are in the realm of FDA. So in 2017, Congress passed a law directing the FDA to come up with a new categorization for over-the-counter hearing aids. And it's meant to be available to direct consumers that they can purchase at the store for individuals with perceived mild to moderate hearing loss. Right off the bat, there are only limited styles. You can't get custom styles. This is a common one that I'm getting asked about a lot recently, is the Bose hearing aids. I'm not against it. I think of it as, non-prescription readers. It's only going to help and reach out to more individuals, but I am all for education and realizing when those over-the-counter hearing aids are not enough, then they might need more help or better devices or better fit devices that are FDA regulated hearing aids. Okay. Right. So I think where we're at now with the FDA is in October of 2021, they proposed a draft of this categorization, and it's expected to be finalized this year. But with the way things are going, I can still see that being delayed maybe later this year, even the beginning of next year. So more to come on that. Okay. So moving forward, I'm really going to be talking about the FDA regulated hearing aids that are out there, not the over-the-counter, because the over-the-counter is limited to technology and the styles that are available. So if someone's coming in to see me for hearing aid consultation or a rehab assessment, I'm looking at all of these things to really decide what is a good hearing aid for a patient. I'm going to take their hearing loss into consideration. For that patient that had a moderate severe hearing loss to profound hearing loss, she was a younger mother in her late 30s or so. What she was wearing before was a custom style. And I really had to say, you know what? This is not enough for you. We need to get you in something stronger. For her, I really talked about communication needs. What she needed was, her goal was to hear her children. She was motivated to get new technology. I have patients that come in here. It's like, well, I'm here because my spouse told me to get a hearing test and to talk to you about hearing aids. So in this hearing aid consultation, I'm going to say, okay, I know why you're here is your spouse pushed you, but are you ready to make this commitment? Because you're the one that's going to have to be wearing it daily, taking care of it daily, and coming in for those follow-up appointments, not your caregiver, not the person that encouraged you to come in. We talk a lot about technology, which I'm going to go over with you. Do they have to rely on others to help them put in their hearing aids or take out their hearing aids or clean their hearing aids or change their batteries? I see a lot of this in senior care facilities where they don't have the dexterity anymore to handle their hearing aids, so that responsibility falls on somebody else. How is their vision? How is their dexterity? Styles cosmetics. I've had patients who say they want the itty bittiest hearing aid possible, but again, they have that severe to profound hearing loss. I'm going to say, I honestly ethically cannot fit you with this. It's going to be like putting earplugs in your ear. So let's talk about options that are right for you. And of course, the costs. That is where what's driving the over-the-counter initiative is finances. So hopefully through this, you can understand where cost is coming from for devices, why things are so costly, what's involved in the process, and understand a little bit better about a patient who wears hearing aid and what they went through. Okay. All right. So many styles out there. I would say the styles really haven't changed in the last 5, maybe even 10 years, but this is the range. First, we have an invisible. These are custom styles here that I'm circling. I would have to take an impression of the patient's ear, send off that impression to the manufacturer. They will build a cast and put in all of the digital components for the hearing aid into the custom shell. So these are of course not going to be available for the over-the-counter. Over-the-counter devices are probably going to be more of the behind-the-ear styles here. So someone with a mild hearing loss that is highly cosmetically concerned and have the right ear canal shape, after I take their impression and measure it, I'll say, yep, you're a good candidate for IIC. If they have a little bit more hearing loss but are still cosmetically concerned, I might recommend them for a CIC. This is just one of the manufacturer's fitting ranges, and you can see that this is for a CIC style. They say, oh, yeah, you're still within range for that. Yeah, let's do it. If that's what you want, you think you can handle it, you still want to change the batteries. You are giving up things like smartphone compatibility, though, with these smaller styles. Okay. So you really have to really take into consideration what they want in terms of technology and their communication needs. But if they're highly cosmetically driven, they're going to lean towards a more invisible solution here. These, I would say, medium or larger custom styles are great for individuals with more hearing loss. It's very popular within the geriatric population because there's not a piece that they have to go behind the ear and then put in the speaker and ear mode in their ear. It's just one ear that can just easily slide in. So if you're working with the geriatric population, you'll still see these styles around. It's just very easy to take care of and very easy to handle. Behind the ear styles, they range from smaller ones. This is still going to be a similar hearing loss range as the invisible solutions here, custom here. If they have more, we're going to have to look into the larger behind the ear. A big change in technology from the standard old hearing aids with the tubing and the ear mode here is manufacturers have taken the speaker of the hearing device or the hearing aid and put it directly into the patient's ear canal. And it just allows for better fidelity. We're not peak clipping sounds. It really allows us to preserve those higher frequency sounds that can often get dampened with a standard tube of just think of physics of taking a sine signal, pushing that through a thin tube, you're going to have some peak clipping. So we can get better, more robust sound when the speaker is directly in the ear canal. Okay. Other things to take into consideration with the behind the ear style is ear modes, domes, and how that affects venting. So whether it's an ear mode or a dome, it really depends on how much hearing loss they have, what they can physically handle, and what's comfortable for them. So I have patients who perspire a lot or produce a lot of wax where it's not a good idea to put a speaker into their ear canal. So we still might go with a traditional ear mode for them. Okay. But the ear mode or the dome, it helps to hold the hearing aid to place, and it really ensures that the sound that the patient needs reaches the eardrum. If we go to smaller option domes where these open domes here, this is more for the mild hearing losses. If they have more of a moderate or profound hearing loss, we might have to consider closed or powered ear mode option. Because if there's pukas or holes in the ear canal, yes, some sound is getting down to the eardrum, but a lot of sound is also leaking back out. So you really have to take into account their hearing loss and how much sound we need to keep in the ear for them. Okay. For the geriatric population, a common thing we have to be mindful of if we do consider an ear mode is the texture. A lot of geriatric population have soft skin. So we do want an ear mode, a harder ear mode, acrylic, where it's more comfortable than a silicone material, which will typically fit for kids because we want it to stay in there. But just for their skin texture, we'll probably choose more of acrylic material rather than a silicone material. Okay. And I brought this up just to show you the differences, I guess, in venting and power of speakers. So where we put the speaker into the ear canal, we can have a medium power or we can have a powerful, or P stands for power. On this medium one, same hearing loss, I put on an instant open ear tip where there's a lot of ventilation that's happening. So it's going to be more physically comfortable, but a lot of sound is going to be leaking out, and we're not going to be within range, and we're missing this area. We're not going to be able to push the higher pitched sounds because there's just too much venting that's going on. We can't keep the sound in the ear canal. So for this patient, I'm leaning more towards a more powerful speaker, but a custom ear mode. Okay, to ensure that we can get them the higher pitch or the higher frequency sounds that they need. Okay, I get a question a lot. Well, what about this lower region here? You might be over amplifying them. I said, yes, that is where, even though the manufacturer recommends no vent, I am going to recommend some sort of venting. Because they're really going to have an occlusion effect because their lower pitches are so good. They're going to feel like whenever they talk, they're echoing in their head. That's the occlusion effect. So I am going to recommend some sort of venting and make sure that I run calibrations to make sure that we're giving them, this individual, what they need. Okay. Okay, moving on. There's a lot of manufacturers out there. In regards to FDA regulated hearing aids, we often hear about the big six. Now it's the big five because Widex and Siemens merged. I usually tell my patients, as long as you stick to the big five or the big six, you're going to be fine. These guys are just considered the big six because they have the funding to always be testing and researching their products and, continuously putting white papers out there. There are off-brand hearing aids that are available if you just Google it. You know, technology is advancing. I just tell consumers or patients, you have to know what you're buying. If you're still feeling like it's not enough, but you paid, you know, $600, $800 online for it, better than the thousands that are available through the big six. You know, if you're not getting that speech and noise, or you want smartphone connectivity, then you might want to move over and consider one of the big six or the big five. Okay. Within the big five or big six manufacturers, there's always a high, mid, and low level technology. I explain it to my patients this way: technology has advanced so much that even the low level technology is going to be better than what hearing aids were 5 years ago. It has just immensely improved. And think of television, where we are today with the megapixels and computers. So even in low level technology, you can still get very good hearing. Okay. The differences, besides cost, is how that individual expects to perform in noisy situations. The higher the technology, the better the algorithm is in a noisy restaurant. I'm going to pick that. And where the microphones narrow in on the person that's speaking and quickly shifts from the dominant speech. It just does a better job. When we go lower in technology, there's still some of that technology there, but that beam is just wider. And that switching back and forth is a little bit slower. So I usually say, you know, if that's not a high priority to you, just know that when you get into that environment, you still may not hear 100%, but you still might catch maybe the mid or the ending of the sentence of what that person is saying. Because again, that slower switching back and forth. Low level technology, there is some of that noise filtering, again, just wider band. Low level technology I always recommend for my patients who have a quieter lifestyle, that are not often in a noisy situation. Most of patients will tend to lean towards the mid-level technology. They don't need all the nuts, the bolts, the whistles. They would lean more towards the mid. Okay. Cost is depending on the level of technology, but it's also dependent on the warranties and the services. And this is where I will have to admit, audiology has to come to a consensus of how we should move forward. I truly believe in unbundling our services so patients really know what they're paying for. That's the motto that we have here at the Speech and Hearing Clinic. So let's just talk about high level, mid, and low. High level technology, just the hearing aid itself can run anywhere from $2,800 to $3,000. Mid-level technology can be, I would say, around $2,000. Low-level technology can be anywhere from $1,000 to $1,200. And then I get the question, well, why is it $5,000 or $6,000? That is where you really have to know what you're paying for in regards to warranty and services. So in top of the cost for the hearing aids itself, that cost is driven by the manufacturer. We have no say in that. That's the price that we pay for. But I want patients to know how much they're paying for the fitting appointment or the testing that we're going to do after, and the verification and the counseling that comes with it. So on top of what I tell patients is we have a standard fitting fee that will include their follow-up visits during the first 6 weeks of their hearing aid use. And that fitting fee for us is about $1,200. So add that on top of the cost that I quoted you guys earlier. Versus even with that, for high end, if we add in the cost of the devices and the fitting services, we are still at around, I would say, 4,200 or lower 4,000s for services and top of the line hearing aids. I'll go through what the fitting process involves in just a second, but I always want to answer that, well, why is another place 7,000? I say, well, what services are they promising you? And they will usually say, well, I get lifetime service. I can go in and see that person however many times I want. And this is where I tell patients, you are paying a lot of money up front for appointments that you're not using. Most patients, once they're after their fitting period, will come and see me maybe twice a year or 3 times a year. And that appointment can range anywhere from $50 to $75, depending on what we do during that appointment. So I would say, okay, they're quoting you 7,000. I'm 4,200 up front, and I believe in paying as you go. Average life of hearing aids is about 5 years. So they're paying $2,000-3,000 of services that they're not really utilizing. So I really have patients understand the difference between bundled and unbundled and the services that they're really getting from their hearing care professional. Okay. All right. I'll go more into detail about the testing that we do in the verification process, but I think the main drive is to really drive for this presentation is to really know what is available out there. So the big thing today that everyone's talking about is rechargeable hearing aids. And this is not necessarily super new, like within the last year. It's been around, I would say, within the last 7 years, but I probably wasn't recommending it to the last couple of years because the first generation of rechargeable batteries were I had a lot of issues with it, sending it in for constant repairs to the manufacturers for shortages or battery life not lasting as long. And with rechargeable batteries, it's great for that patient with poor dexterity because they don't have to fuss about, changing the battery anymore. But it's still mainly in this receiver in the ear technology. And like I mentioned a few slides prior when we talk about styles, if they have poor dexterity, this still may not be the option for them to go to. So it's really just the convenience of not having to change the battery every week or every 2 weeks. Even with rechargeable batteries, I still tend to push towards a couple of manufacturers where if you kind of squint and look in, there's a hinge right here. So the patient wouldn't be able to open that battery door. But if they're having a charging issue, I'm able to get in there and maybe change their rechargeable battery for them. I still recommend something like this versus this is Phonak, where I, as a provider, don't have the option to get in there and to maybe try and fix their charging issues because it's a closed rechargeable option. Meaning that if there's a battery issue, I have to send it to Phonak, which being in Hawaii, it takes about a 2.5-week return to get back to us after they repair it. So I like the option of, hey, maybe it's just as simple as just changing the rechargeable battery that I can do in office. So there are different types of rechargeable options out there. Okay. Everybody loves smartphone connectivity. I love it. I'm a huge fan of this, and it's really it's just wonderful, especially for our baby boomers that are now getting older. They're just all about technology and being able to hear directly from their phones. So Apple, of course, was the big spearhead in this initiative with smartphone connectivity. Before that direct connectivity, all manufacturers had what we call a streamer option. So as long as as the phone has Bluetooth, we could pair the Android or flip phone, whatever, as long as it has Bluetooth, to the streamer that the patient wears around their neck. And this streamer will then wirelessly connect to their hearing aid. But maybe in the last 4 or 5 years, Apple has done away with this middleman device where we just pair directly through their settings, accessibility in their settings, where we pair their phone directly to their hearing devices. And this is just fabulous. Someone calls them, they just hit answer on their iPhone and they can hear the conversation in both ears. iPhone has that technology, or Apple has that system with all manufacturers. Android is catching up. So, and if I ask the patient, well, what smartphone do you have? And they say, I have an Android. Well, I say, well, I'm going to lean you more towards Oticon, or I'm going to lean you more towards Resound, because they have some Android compatibilities where you can have that direct streaming option. And again, they don't need to wear this middleman device, and they can hear the phone conversation. They can download an app. They can increase the volume, decrease the volume, toggle through their different programs, even have some adjustments in regards to bass, middle, and treble. So great for my music lovers because they can get in and adjust the treble. Oh, I want to hear the woodwinds. Oh, I'm going to increase the treble. Oh, I'm having difficulty hearing speech. I'm going to increase the treble in the mids to help them. So they have some control right then and there. Okay. Now, I forgot to add that high, mid, low technology. When this first came out, it was only available in the higher level technology. But because of how far technology has gone, you can get iPhone or Bluetooth connectivity even in a low level technology today, which is fantastic. Okay. All right. This isn't necessarily something new, but it's something that's often forgotten about. So in airports, you probably see this symbol here. Okay, and it's a hearing loop telecoil system. So this has been around for many, many years. What it is, it allows the hearing aid user, if their hearing aid is compatible and has that technology, they can push a button on their hearing aid, or they can push a button through their app or their remote control and switch into that telecoil system. And that will allow that individual to hear what, this is flight 462 departing at gate 36. They can hear that broadcasting directly through their hearing devices, so they don't have to miss the announcements that are happening at the airport. I haven't seen it here in Hawaii yet, but I used to work in Florida and Seattle, and I get a lot of snowboards. I love theater. But a lot of theater, ballet hall, concert halls have a loop system. So if they, maybe they come for their fitting, it's like, oh yeah, I go see the ballet a lot. I might ask them with theater and ask them or call them or look it up online. Do they have a loop system? And they may or may not, but even if they don't have a loop system, I know Ward has some options in terms of if you give them your license, they will loan you a personal amplifier device that connects with their movie. So they can hear the dialogue better. So I apologize, I digress. But there is that hearing telecoil loop technology that has been around for years, but people forget about it. Okay, so I just kind of want to put that out there again. Okay. Hearing aid technology, television is another big one. So what you see here in these images is a television device that this box links up with the audio ins and outs of the TV, red, white, and digital cable here, aux cable. And as soon as the patient walks in the room and is within, I think it's like 16 feet or so, or 20 feet maybe for some manufacturers, it will automatically kick into the television program, and they will hear the television dialogue streaming directly to their hearing devices. So this has advanced in a sense where there's no middleman streamer that they have to wear around their neck anymore. Au.D, another manufacturer, has that direct where they just walk in the room and they can be directly connected to their television, which is awesome. This is not new, but for individuals who may not have a smartphone, but can't reach or feel to change their buttons, just a reminder that there are remote control options available where they can still change the volume or change the programs of their hearing devices. This is a lapel microphone, great for meetings, great for individuals that are going back to school or going to school. They would give this lapel microphone to the person they're talking to, even great in restaurant situations where they can give it to their family member that they're having, or their friend who they're dining with, and it allows for that direct streaming of their voice to their hearing aids. Okay. Okay, so during the consultation, I talk about this very quickly. I have a spiel now. I've done this so many times, but all that information is shared with them during that consultation meeting, believe it or not. And by the end of it, we really say, okay, patient B, you're still working, you're very active. I wouldn't go any lower than the mid-level technology. You're cosmetically concerned. So I would say consider, if you want consider the invisible solutions, either the custom or the receiver in the ear style. But if you want smartphone connectivity, then we're going to have to go receiver in the ear. Okay. So all of that happens by the end of the consultation. We select the device that's for them. I say, okay, great. I need to order devices. It gets here in about a week or 2 weeks. I'll see you for your fitting appointment. Then after that, there's like, oh, I got to see you again. I was like, yes, you got to see me again. You got to see me during your, like, circle that green area during your trial period, because I really need to make sure that we're programming these correctly for you. And that's what a lot of people don't understand, is that there is proper care that happens after the fitting. Okay, so I'll dive into that a little bit more. The fitting appointment.
I know this is like super wonderful and amazing, and everybody loves slides, but we're kind of running short on time. I was just kind of wondering if they can wrap up soon.
Yep. I will touch on just this, and then I think everything else can kind of be there for you guys to reference. Awesome. So fitting appointment, we're confirming fit, where there's initial calibrations that we do, even a hearing test with the devices in the ear. We go over use and care. The acclimatization period, that's that trial period. So I always tell patients, I don't give you your full prescription on the first day. We have to gradually introduce you to all that volume. So that's why we bring them in every week or every 2 weeks. There's testing that we do with the hearing aids, without the hearing aids, this real ear measurement. We're seeing how the sound travels down their ears. We follow up on those questionnaires that I talked about earlier. If I see that they're a good candidate for auditory training or oral rehab, that's when it happens. That's where I say, okay, you're missing the S sounds, and I will drill that into them. I'll do it in quiet, I'll do it in noise, I'll do it with vision, without vision, to really make sure that we're maximizing the hearing aids and seeing if we can really get them all of the sounds that they can hear. If not, then I maximize the technology. I provide an auditory training and they're still not doing, then that counseling happens on that realistic expectation. Follow-up plan, again, my patients I work with, I see them probably for the rest of their life or the rest of the hearing aid life. So I am going to recommend annual hearing tests, and that follow-up doesn't have to happen every month. It doesn't have to happen every 1 or 2 weeks. Depends on how much wax they build up. Most patients come in twice a year. Some patients come in 3-4 times a year, depending on how much wax they have. Okay. Beyond the hearing aids, communication strategies. This is what's shared with patients. This is usually what I give them to share with their caregivers, family members, and how to communicate with someone who has hearing loss. I won't go into detail. Getting a lot of questions recently, because AARP just had an article in their paper about, am I a cochlear implant candidate? So I just provided that there is a certain range, certain testing, and it really is last resort. We have to really prove that they have no hearing aid benefit. Okay. Other devices besides hearing aids, so bringing up patient A, who really is not affected, but hey, she's still saying she wants to improve watching television. I might recommend TV ears. You see that out there here today. So there are personal amplifiers, pocket talkers, that again, not $800 or $600 like the over-the-counter hearing aids, but $100, where they can still get some amplification and hear their doctors or whoever comes and visits them. Okay, that's it. Sorry if I went a little over, but that's it from me.
Oh my gosh, this is like an avalanche, a water hose of like amazing information stuff I've always wanted to know. And of course there's even more. So I don't know how, I just want to make sure you'll be able to share these PowerPoints that we'll put up on our website that everybody can access and do that. And, I guess they can ask you questions directly if they have. But we have a couple of really quick, I don't know if they're quick questions, but is there typically insurance coverage for hearing aids?
Medicare does not cover. Second parties, TRICARE, HMSA, Quest plans do cover. Not everything. They may just cover the devices and they may not cover the services. So that's where I really have patients understand that unbundling model to really know what they're paying for.
Great, good questions. How about the, I think there's a question about, is there a Find My Hearing Aid app?
There is. So
that's always getting lost, right?
It's very it's neat. It's within the manufacturer app itself. If they open up the app, if their hearing aids are on, that's the trick though. The battery has to be charged and it's on. Let's say they take off their mask and hearing aid goes flying. They can, or at the grocery store, it will show them that the hearing aid is on and at where they left it last at the grocery store where it fell off. So there is it's a hot and cold game. If you get closer, it'll kind of beep at you and let you know that, hey, it's really nearby.
Great. I guess smartphone compatibility is a device controlled by the app. So actually, I think you described it a little bit, right? That you
Yeah.
actually can control the details of
Some. Yeah.
programming.
Yeah.
What's the average time period to renew the hearing aid since technology changes constantly?
I have my tech lovers that will come in, I would say every other year to get the latest and the greatest. But most patients will notice the huge technology change in terms of clarity, in terms of speech and noise processing. I would say every 5 years or so.
How about any suggestions for cerumen buildup prevention?
Mm. Um, those follow-up appointments. So having that hearing care professional look in their ears. I say whenever you're in an office where they have an otoscope, if it's the nurse or if they have them look in your ear, just say, I wear hearing aids. You mind looking in my ears? So I have wax in there. So I encourage patients to be an advocate and to know. And over time, the more I work with them, I say, oh yeah, you're good every 6 months or so. And I'll look in the ear, I'll remove it if need be, or I might refer them to their physician if it's more involved.
Great. Is there a best way for patients to clear the cerumen from their earpiece?
That's something we go over at the fitting and all of the follow-up appointments is how to clean their hearing aids. And again, if they're not able to, it might fall on the caregiver, but it comes with little microfiber, like the glasses cloth that you can get. It comes with that, but you don't need that. You can use a paper towel or a dry cloth, wipe down the ear mold, wipe down the dome, wipe down the body of the hearing aid. Brush, no solvents, no dry. They are plastic, mainly plastic. So if you alcohol base on to sterilize, with COVID these days, you are drying out the plastics and they can crack over time. So it can shorten the lifespan. Brushing. It comes with a little brush, but I honestly prefer a good old toothbrush that gets in there and you brush off all the wax that comes that can build up on it.
Great. Yeah, I had a question. I guess you pointed out that there are some reversible causes of hearing, right? Such as like diuretics and aspirin and stuff like that. So I wanted to see if Chad could comment on that a little bit with regards to dosing, so we can prevent this stuff. And then I had a question for you about, do you not do hearing aids for people with drug-induced ototoxicity in this case they reverse? Yeah, Chad?
Oh, thank you. Thanks for that. And yeah, when I saw that slide, I was like, it was near and dear to my heart, of course, as a pharmacist. So anyway, a couple of things on the loop diuretics. So most of the loop diuretics that cause ototoxicity, we're talking about like the high frequency hearing loss and tinnitus. But most of it is always reversible. So rarely ever does it become permanent when we're talking about your loop diuretics. So like your furosemide and your bumetanide, because of the the potency of those agents, it's going to be dose related. So for example, in the hospital, if you're giving like furosemide in excess of like 80 milligrams push, the patient might complain of some hearing loss. So for some of the hospital practitioners out there, the ototoxicity and the tinnitus is going to be dose related. So we try to keep the doses somewhere in the mid-range. I would say for IV, furosemide 40 milligrams IV, or Bumex, 1 to 2 milligrams IV would be sufficient to start. That's pretty much all I got. I mean, as far as the aminoglycosides, that has gone to kind of to the wayside because of not only the ototoxicity, but the renal and nephrotoxicity associated with that medication. So, haven't used it a whole lot, primarily because of that and the small therapeutic windows that make it so very difficult to prescribe and monitor. We've gone to other antibiotics that are a lot less toxic. Other than that, that's all I got. Thanks for the in.
Thanks. Now, how fast is it reversible?
It's usually reversible quite quickly. I mean, so within the half-life of those drugs aren't very long. So once it starts to decrease, it should go away. Some patients will complain for like a day or two, and then we drop the dose, and then in a day it's better.
Good to know.
If
Okay, great.
the problem becomes if the patient complains of hearing issues and we continue to push the dose, or we do nothing, and that's when it becomes more of a problem, and then we can start to see permanent hearing damage. But once it happens and you back off, usually you're still going to be good to go.
Mhm.
All right, just want to point out we have CME evaluation link in the chat box, so please click on that and make sure you get your CMEs. And with that, I am gonna say thank you so much, Lisa. This is great, and we're gonna, for everybody else, we're gonna post the PowerPoint slides that you can download yourself and take a look in more detail. And I guess now we'll be referring more patients and knowing what we're talking about maybe a little more when discussing hearing aids.
Thank you.
Thank
Thank you.
you
Thank you
so
for having
much.
me.